So
ದ್ರೋಣಾಚಾರ್ಯರಿಗೆ ಪ್ರಣಾಮಗಳು.
ಪ್ರಣಾಮಗಳಪ್ಪ. So robotic surgery is coming on by leaps and bounds in terms of being one of the established methods of treatment in certain situations. Though people who are enthusiastic about it will use it for everything, I think it will be an overkill, as Indraja will talk about it later. But certainly it is definitely is one of the tools in the armamentarium of a surgeon, and many of them it will probably be one of the definitive indications for robotic surgery. There was as of now, according to the established thing, the retropubic radical prostatectomy was the original indication for robotic surgery. Subsequently, now low anterior resection, ultra low anterior resection, maybe abdominal perineal resections, and certain thoracoscopic procedure, and also esophagectomies have become fairly good and standard indications for robotic surgery. We will talk about the evolution of it and how it has sort of come into its own in certain situations. Unfortunately, I have only assisted robotic surgery. I have not performed it myself, so I'll not be in a position to. I tried to see if we could get somebody who would do regular robotic surgery, but because of short notice, we couldn't find anybody. So we will just talk about it from the theoretical perspective and to understand how it is done, and we can arrange for demonstration now that COVID has come down and surgeries will be starting on regular basis. We can find somewhere where we can demonstrate robotic surgery for you guys. Though you can find YouTube videos, but nothing like going and watching it live, how the docking is done, and how the system works, everything, how the surgeon performs the surgery. All these things you have to watch it live to understand it. So we'll see. Okay, Indraja, you can start.
Am I audible, sir?
Yeah.
Good evening to everyone. I'm Dr. Indraja, second year surgery resident in Saga Hospital. Today, I'm going to discuss about the robotic surgery. I'm going to talk about the history and different types of robots and their applications, advantages, and limitations. And the robotic surgery has been embraced by the surgical fraternity and has been unparalleled. And it has driven in part by rapid developments in technology, and in part and has been made in adaptations have been made to the existing laparoscopic procedures and techniques. And the robotic procedures are rapidly becoming the new standard of care. And the term robot was coined by Karel Capek. It is the term originating from the robota, which means forced labor. Over the time, robots have become highly evolved compared to the ancestors, and the robots that are present today are very precise and highly specific in performing hazardous jobs, which are done by human workforce in the years ago. And the first robot which was invented is Puma 560 in 1985 by K. Waugh. It is programmable universal manipulation arm. It was discovered to perform the high precision neurological biopsies. Followed by that, ProRobot was invented in 1988 for the transurethral resection of the prostate. Then later on, the Robodoc was approved by the FDA in 1992 for hip replacement surgery. These computer-aided surgeries resulted in the clean cut cavity with precision and perfect fit of the prosthesis. And in 1980s, NASA's Ames Research Center began working on the virtual reality, and they invented the concept of the telepresence in surgery. And in 1990, NASA, along with Stanford Research Institute, they helped combine work and developed a telemanipulator, and which went on a long way to overcome the limitations of the minimally invasive surgeries. And the another system called MASH, Mobile Advanced Surgical Hospital. It is a remote surgical robotic system. And the telepresence was initially developed in the US Department of the Defense because of the most of the 90% of the fatalities in the combat situations were caused by delay in reaching the medical center. So to provide the immediate assistant to the wound soldiers, that telepresence was initiated. And in 1996, automated endoscopic system for optimal positioning was created by the computer motion using voice control technology. And with few modifications in 1988, ASAP 3000 was released. And this technology later on used in the Jesus robotic surgical system. GS robotic surgical system.
Zeus,
Zeus.
not Jesus. Zeus.
And Isaac Asimov, he's a science fiction writer. He proposed 3 laws of the robots, of which 2 will surely apply to our modern concept of medical robots, of which law 1 is the robot should not injure human being or through inaction and allow human being to come to harm. And the law 2 is robot must obey the orders given by the human beings except where such orders would conflict with the first law. And there are 3 robotic systems has been developed, which includes active, semi-active, and master-slave systems. And the active robotic system, which works autonomously, and the semi-active robotic system, which were pre-programmed but allow the operator to complement the actions. And the master-slave systems, these are the they don't have the pre-programming and they completely depend upon the operator. And this is the system we are using current robotic systems. There are different types of robotic surgical systems, which include supervisory control system, telesurgical system, and shared control system. The supervisory control system, it is the most automated type of surgical robot, and a lot of surgeon involved pre-work must be done before the robots can perform, and it allows extremely detailed set of instructions which depends upon the input from the surgeon. It includes 3 steps. In the first step, the surgeon takes lot of details and mapping the body as well as region of interest and collects pertinent data. And in second step, the includes registration. Surgeon uses the collected body image of the patient and connects it to set of corresponding spots on the real-time image of the patient. And the third step is the actual surgery, where surgeon places robot in first position and it performs and completes its instructions. And the supervisor control system, it includes the robotic radiosurgery systems are the part of supervisory control system. It delivers radiation for the treatment of the tumors from remote location. So it has a lower risk of over exposure of the medical professionals. The main drawback of the supervisory control system includes once instructions have been input and sequence initiated, there is no room for error as there is no way to make any adjustment to the procedure in real time. The telesurgical system, it is also known as a remote surgical system. The surgeon is the main console manipulating the arms of robot in real time. While technically the procedure is performed by the robot and surgeon is controlling the movements of the robot throughout the procedure. And the shared control system, in this system, surgeon is involved the most and surgeon perform the procedure with help of the robot as an assistant to offer steady manipulation of the instrument. It is often used for the neurosurgery and orthopedic surgery procedures. Can I continue, sir?
Yeah, just a minute.
Yes, sir.
Any questions so far? No questions in the chat room. Anybody?
As you put the headings, you should have shown the figure also, no, side by side.
Yes.
So that it would have helped understand.
Yeah, are you going to show the figures, Ma? The pictures of the different robotic systems?
Yeah.
Sir, I have the Da Vinci and Zeus robotic.
Whatever you are describing on the side, you should have put the figures and shown, means it would have been more beneficial. Okay.
Okay, continue, Ma.
Yes, sir.
Okay, continue.
Yes. There are many robots has been researched and developed, and Skur et al. From the University of the Calls for minimally invasive surgery, they invented master slave manipulator system known as Artemis in 2000. It consists of two robotic arms that controlled by surgeon at a control console. And Dario et al. From the MITech laboratory in the Italy, they invented prototype miniature robotic system for computer-enhanced colonoscopy. It provides same functions as conventional colonoscopy, but it does with an inchworm-like locomotion using vacuum suction. There are different types of robotic system using nowadays. These includes Da Vinci, Zeus, and Cyberknife Mako Surgical Corp, Socrates System, Raven 1 and 2, and MiroSurge robotic surgery system and TraumaPod. The Da Vinci system, it is the most common robotic system using nowadays. It is evolved from the Tele presence and developed by NASA and US Army. It consists of three essential components, which include surgeon console, patient cot, and vision cot. This is the image showing surgeon console and patient cot and the vision cot. And the surgeon console consists of stereotype viewer, right and left ports, and the foot switch panel. And the patient cot,
Describe slowly.
Yes, sir. The surgeon console, which consists of a stereotype viewer, sir, it provides the video of the video, and the left one, and the left and right ports, and the foot panel switch, which it is used for the focusing of the camera and the energy devices. And this is the patient cot, which includes endorist instruments and the camera and touch screen monitor and instrument areas. The camera arm contains dual cameras, and it generates three-dimensional image. And the master console, it consists of image processing computer, viewport, and foot pedals, and master control grips that drive the servant robotic arms at patient side. And the robotic system, it allows 7 degrees of the freedom of movement. That and when compared to the laparoscopic, it only allows the 5 degrees of the movement. The extra 2 movements are the wrist and wrist pitch, which is not possible in the laparoscopic surgeries. And the instruments are capable of provide a 7 degrees of freedom, and it displays 3-dimensional image. It gives the surgeon the illusion that tips of the instruments are an extension of the control grips, thus giving the impression of being at the surgical site. And the Zeus system, it composed of surgeon control console and three table robotic arms. The 3 robotic arms are attached to the side of the surgery table, and the one robotic arm uses the voice activated ASAP technology. The other 2 arms are the extensions of the right and left arms of the surgeon. And surgeons sit at the console with specialized polarized glasses that create a 3D image. This instrument handles positioned ergonomically to maximize the dexterity and allow the complete visualization of the operating room environment. And it uses both straight shafted endoscopic instruments similar to the conventional endoscopic instruments and jointed instruments with articulating end efforts and 7 degrees of freedom. This is the image showing the Zeus robotic surgical system, which includes surgeon console and the 3 robotic arms attached to the operating table. The Cyberknife Mako Surgical Corp, it is a robotic system which uses shared control system. It was invented in 2001, and it is the very first image-guided robotic technology for non-invasive radiation procedures. It includes following features like compact, light, weight linear accelerator mounted on robotic arm, 2 flat panel cameras, and dynamic tracking software, Synchrony, that are tracking the vest with LED markers, and camera array with 3 CCD cameras. and it is used for the treatment of the lesions, tumors, and other conditions. The Raven, it was designed by the army as teleoperated system. It is adapted as a research tool in many fields like surgery, computer science, and engineering. Raven 1 was invented in 2005 and few modifications was made to the Raven 1, and Raven 2 was invented in 2012. The main features of Raven 1 includes the patient side, that is slave, and surgeon side, master, and the network connecting to the two. Raven 2 has the following improvements when compared to the Raven 1. It includes a tool interface redesigned for cable-driven tools and adapted to the commercial surgical robotic instruments. Actuation of the 7th degree of the freedom, gripper with three-axis wrist, and more compact mechanism. And the Socrates system, it was invented in 2001. It allows the worldwide remote access of surgeon with another operating surgeon. The surgeon can hold discussions as well as they can view the video images generated by overhead or endoscopic cameras. The Socrates has given new definitions of telemonitoring, telesurgery, and telestration. Telemonitoring, it is a use of this technology in teaching surgical procedures via video conferencing technology. And telesurgery, in this, the surgeon can perform the operation from a remote console, and the location may be within few feet or miles. And the telestration, the surgeon draws on a tablet to the virtually illustrate on local surgeon's video screen. This can be used to highlight region of the interest. The MiroSurge robotic system, it is a robotic system in as minimally invasive surgical procedures, but also has the versatility to be used in open surgery. It has two types of interfaces. One is bimanual haptic type of force and partial tactile feedback, gives direct perception of the remote surgical environment. The other type is surgeon can control the instruments by optically tracked handheld forces. The MiroSurge has the following features like haptic feedback and two surgical arm holding instruments and bimanual configuration with axis, one surgical arm with two endoscopic high definition cameras which provide a 3D image, and contact free interface, and dedicated left and right handed control, and 7 degrees of freedom of movement. This system was designed with both minimally invasive robotic surgery and open surgery in the mind. And the future improvements can allow the surgeons to do the heart surgeries without stopping the heart. The trauma pad, it was designed which will actually the modern day the mobile advanced surgical hospital unit, which will receive access and stabilize the wound soldiers. The trauma pad is being designed based on these needs, and the present prototype has a team of robots to assist it, and all of them controlled by a remote surgeon. It has following features: 3 arms on a lead robot. It monitors the vitals, administers fluid and oxygen, and it also performs the anesthetist functions. And the voice activated robotic arm work as a scrub nurse, and tool dispensing robot act as a circulating nurse, and software controlled monitoring to avoid collisions. The main use of the trauma pad used to in combat areas via telesurgery and telecommunications while protecting the actual surgeons in the remote locations. It includes 4 steps. The first step, the loading the wounded soldier into the pod via fully automated medicine. In the second step, the complete initial scan and administration of the oxygen, fluid and blood infusion, as well as the processing, pre-work for the triage and treatment. And the third step, remote surgeon teleoperating the instruments to stabilize the patient. And in final step, airlifting the injured patient via evacuation helicopters to the nearest field hospital. Can I continue, sir?
Yeah, no, we'll stop now.
Yes.
Any questions or comments so far? Abdul?
Sir, one doubt, sir. Sorry, sir. Sir, is it the haptic feedback and tactile feedback both are same meaning, sir? Is it different terms, sir?
haptic feedback is a feedback given by the tissues back to the surgeon. Tactile feedback is the feedback that you receive by feeling the objects. They may be one and the same, but I think there is subtle difference.
Okay.
So for example, let us say you touch liver. The liver has a certain consistency and it gives you a feedback saying it's a firm to hard, structure. So you know what is there in that location. So it's liver. So it is the feedback of the organ or the instrument that is touching the organ is the haptic feedback. The tactile feedback is while you are actively touching in a particular structure, then you get a little bit, I think with hands you get full feedback, you know what it is. For example, if you're touching an artery, you will get the pulsations, everything. But here with the instrument touching, you may get a little bit of it, not fully. So that is tactile feedback. Maybe it is very subtle difference, but there is a subtle difference.
Okay, sir.
Any Abdul? Any questions?
No, sir, nothing.
Kavya?
No, sir.
So basically at the moment,
I think whatever you have described, you should make a short video and demonstrate all those things. It's very difficult to follow this theory.
yeah, I think that is the thing.
The one thing you follow next, when you come to the next step, you will forget the previous one.
So basically, the various systems, they're all about the same. There will be subtle differences between the various systems, but currently the Da Vinci systems, manufactured by the intuitive systems. So that is the robot that is now used on a regular basis all over the world. There are other systems. The Cambridge system is also coming up in India in a big way, which actually splits the Da Vinci system has one big the console which is docked to the patient. The new Cambridge systems has smaller units which do the same job. So sometimes you may not necessarily need to use all the four arms of the Da Vinci. So in that case, you can use the smaller systems, which you can use 2 or 3, depending on how much you need. So that is the advantage. But I think ultimately, as of now, the Da Vinci systems are the market leader. Their patent has run out now, so hopefully the costs of robotic manufacturing and usage will come down. The main cost, apart from the instrument cost, is the recurring cost due to the instruments are manufactured in such a way that after 5 uses or whatever, 4 or 5 uses, you have to change. So that is the recurring cost is very expensive. That also adds to the expense to the patient. And in India, what we usually do, for example, even if it's a single use catheter or whatever, the hospitals use it many times and then charge each time. So they make money out of it. But Da Vinci systems are very clever. So they have locked it in such a way that after 4 or 5 uses, you can't use that particular, you have to throw it away and buy a new set. So otherwise the system doesn't work. So you cannot cheat the system. As of now, I don't know, Indians may find a different way of doing it, but as of now, that is the situation. So I think we'll come to all the applications of robotics. So far, I think she's given us an overview of the current systems that are available in the market. I think Indraja,
Yes, sir.
if you find videos of the various systems, how they work, a short video of 5 minutes each, if you find it in the next, just post it in the group. Okay.
Yes, sir. I will do
that way we can watch it. Okay.
Yes. Okay.
Any other questions?
No,
Pawan?
you can present it. You can have a discussion on that. What is that?
Yeah, we can have a class.
Any doubts you can clear it or clear it. And you can call one of the Somo or someone
Yeah. We'll next time we
Yeah,
will
you
give them
can
enough
clear some
notice. They will
details.
come. They will
Yeah.
certainly come.
Can call Shivaram.
Shivaram doesn't do robotic surgery.
Okay, sorry.
So Somu athwa Ashish yararu
Yeah,
karibeka.
whoever.
Anybody else? Pawan, you have any questions?
No, sir.
Hello? Talk up, speak up, man. Janani, have you joined?
Sleeping, I think.
No, sir. Janani has not joined.
Janani has not joined. So we'll extend her training period by extra 1 week, because I told her today to join the class. She's not joined. So I will extend her. I will not sign her form for 1 week after she finishes the training. Okay, continue, Indraja.
Yes, sir. And the different applications of the robotic surgery in different fields of the in different fields. In the robotic surgery, in case of gastrointestinal surgeries, it most commonly used for esophagectomy and colectomies, and also used for Heller's myotomy, gastric bypass surgeries, splenectomy, and adenolectomy. And the robotics in robotic urological procedures, the most commonly performed procedure is robotic prostatectomy, then nephrectomy and pelvic lymph node dissection.
Indraja, it's procedure, it's not procedure.
Okay, sir.
Procedure. Okay.
Okay.
Where did you learn that procedure? In America, is it?
Procedure. Okay.
Procedure. Okay, sir.
Some people call procedure.
Carry on, ma.
Yes, sir. And it is also used to perform hysterectomy in case of gynecological procedures. And in robotic cardiothoracic surgery, it is used for coronary bypasses, sternotomy and thoracotomy, and lobectomies and tumor enucleations. And in oncological surgery, it is most commonly used for colorectal cancers and esophageal tumors, and thymoma and retromediastinal tumors. In case of pediatric surgeries, it is used for the pyeloplasty for uretropelvic junction obstruction and pediatric congenital heart disease for the ligation of the patent ductus arteriosus. And I'm going to talk about the rollout trial. It is a randomized control trial to see the effect of robotic assisted versus conventional laparoscopic surgery on risk of conversion to open laparotomy among patients who are undergoing for resection for rectal cancer. It is the study conducted by David Jane et al. In 2017. They compared robotic assisted versus a conventional laparoscopic surgical procedures in patients who are undergoing resection for rectal adenocarcinoma. They included 470 patients, and this study was conducted along 10 countries, including 40 surgeons. And of this, for 471 patients, 237 patients underwent robotic assisted surgeries, and 234 patients underwent conventional laparoscopic rectal cancer resection. They performed high, low anterior resection and abdominoperineal resection. The primary outcome was conversion to open laparotomy, and the secondary endpoints included circumferential resection margin positivity, quality of life, bladder and sexual function, and oncological outcomes. And they said that comparing robotic versus conventional laparoscopic surgery, it did not significantly reduce the risk of conversion to the open laparotomy. And surgeons, and it also said that the surgeons with varying experience with robotic surgery does not confer any advantage in rectal cancer resection. Can I continue, sir?
Yeah. See, I think basically, see, there is something called non-inferiority trials. Okay.
Yes, sir.
Does anyone know what non-inferiority trials are? Abdul?
No, sir.
I've not heard about it.
Kavya?
Whether, like, when evaluating compared to standard treatments, that they are not lesser than the gold current standard.
Basically, non-inferiority trials are done to show that the procedure that they are studying or procedure they are interested in is not inferior to the standard currently accepted standards, and basically there is a difference that they usually, it can be 5%, 10%, whatever. So they do these trials to show that this particular procedure is no way inferior to the current standard. So that is one of the this one of the this roller trial. So it started in 2017, as Indraja said,
Yes.
but it was reported in 2019, 2020. They wanted to show that the robotic surgery is superior or in no way inferior to laparoscopic surgery, considering all those primary and secondary endpoints. And they ended up showing that it does not confer any particular advantage. So basically it shows that you are promoting something which is just being promoted for the sake of the industry, with no specific advantage in terms of either oncologically. Actually, to just take this point a bit further forward, Australian trial looked at open surgery for anterior resection and abdominoperineal resection for rectal cancer. Compare that with laparoscopic surgery, compare that with robotic surgery, and showed that oncologically, even today, open surgery is superior in terms of the achieving circumferential resection margin, freedom, lymph node harvest, and preventing local recurrence. So, and all the what is called as the minimum data set for rectal cancer outcome reporting by the pathologists. So when you look at all the, if you look at a pathology report of a rectal cancer, there is a photograph of the printed on the report showing the circumferential resection margin, also showing the specimen. The specimen should appear cylindrical rather than appear as a cone. And then there are so many definitive factors that they list out to show minimum data set that is required for a proper reporting of the rectal cancer. So when they looked at all of that, they showed that open surgery is still marginally superior to laparoscopic and robotic surgery. But however, robotic surgery was pretty decent in terms of achieving the oncological outcomes as with laparoscopic surgery. So it is not, see, the thing is, unless we continue to stretch the horizons and push the boundaries, we will not achieve the next generation of treatment or whatever. So why we should not dismiss robotic surgery as something is a fancy. But however, we should also not fall prey to the marketing that is being done to show that it is superior to all the methods that is there. As of now, trials have not shown any superiority with the robotic surgery compared to the standard laparoscopic surgery and open surgery. So that is as much, this is the latest trial that is there. 2019, 2020 it was reported. I don't think there are any further trials which have come out. Maybe then a few newer ones may show some difference. But the thing is, the cost is an overwhelming factor, and the time taken for surgery and all these things. So I think as of now, robotic surgery in rectal cancer has definite role, but it has to be used with with care and caution. Okay, continue. Any questions on
I
whatever?
heard some US centers, they are abandoning this robotic surgeries.
Correct. See, the thing is, basically I know it is not what we call as cost effective, because I think here I correct me if I'm wrong. I think Manipal charges between 2 and 2.5 lakhs extra over and above the cost of the
Don't
surgery.
compare here, man. This is a purely commercial. There's no ethics here.
Alla, na ಹೇಳ್ತಿರೋದು.
Even now, I was seeing the people doing for even inguinal hernia.
ಅಲ್ಲ ನಾ ಹೇಳ್ತಿರೋದು, I'm just purely
2.5
talking
lakhs
terms.
extra, correct.
I'm not talking about the indication. I'm just talking about the finances.
Yeah.
Finances
yes.
compare ಮಾಡಿದ್ರೆ, I think basically when I was in England, I don't know whether costs have come down. when I was there, each surgery would cost, it had to get permission from the hospital committee, because everything is funded by the government. So there is a committee which will fund these things. So each surgery would add 10,000 pounds, which in Indian money will be about 10 lakh rupees. So 10 lakhs extra per each case. That was the cost. So, for you to justify, even in America, I'm sure that is the same. Now, with the patents being the one end of the patent for intuitive systems, whether the manufacturing and usage of robots will become easier and cheaper, I don't know. But even in US, I think it used to be very expensive. So the insurance companies demanded what is the advantage of using this. So that is why they have abandoned, because insurance rules the roast in United States. And if they don't find it cost effective, they will not approve that. So unless the patient wants to pay for it himself, the insurance will not pay for it. So that is why many US institutions have abandoned the robotic, and all those systems are being exported to India. And many of them are lapping it up, saying that we have got the best systems, but they are all very old systems that they are getting. So that is the current status. But I think robotic systems are here to stay. They will continue, they will improve enormously, and they will form a definite level of in the armamentarium of the surgeons. But we should be careful in using it for the right, as you said, Srikanth, for right indications. As of now, I think, speaking to my cardiac surgeon friend, he thinks that cardiac surgery is extremely, it is extremely beneficial for, both CABG and valve replacement. So, now this one is coming out, is a single, like sills. The arms are going to be like the sills procedure. They will be, very fine arms, which will be able to rotate and turn at 360 degrees and everything, and they will be sort of introduced through a single port, like it's called the octopus. So I think that is the new system, which is probably, he says, that is going to be very good for cardiac surgery. So I think definitively, and I have seen with my own eyes, there was a gynecologist who was operated that morning for a CABG, and afternoon around 4:30, when I went to see my friend in the coronary care unit, this fellow was already walking. He was very comfortable. So no doubt, which you would never have found with the open heart procedures. And with minimal invasive, that same advantage is there. And with the robotic, he says the advantage is even more pronounced. So, but again, this is all marketing thing. Definitely there is an element of marketing in most of what they say. So, hard evidence, scientific evidence has to be taken into consideration when we, talk, in this forum. And as of now, that is why, even when you saw Srikanth that day in the Manipal conference, it's one surgical clinical meeting, Somu usually would get up and counter anything that is wrong. He didn't counter me. So he knew that what I was talking was right. So I think there is no doubt at the moment. The indications are being fudged, but hard indications, as far as I can tell, is retropubic prostatectomy, definitively, and for very low, ultra low anterior resections, and maybe AP resections. Again, AP resection, I don't think it offers any major advantage, but ultra low, maybe it will. And for esophagectomies, and as far as open heart, this one, coronary bypass and valve replacement surgeries. I think that currently those are the hard indications for robotic surgery. The rest of them are being used as and when the surgeon wants it and the patient wants it, and the way it is marketed. Okay. Any doubts and any comments on what I have just said? Abdul?
No, sir, nothing.
Kavya?
No, sir.
Hari?
No, sir.
Okay, continue, ma.
Yes, sir. Now I'm going to talk about the advantages. This include technical and clinical advantages. The technical advantages includes it allows the enhanced stabilized three-dimensional stereoscopic vision of the operative field, and it increases the depth of the depth of perception beyond the standard laparoscopic monitor, and it also has ability to zoom without sacrificing the clarity, and it has increased maneuverability of the articulating wrist movements that created additional degrees of the freedom from 5 movements to 7 movements. And it also includes the hand stabilization, eliminates surgeon tremors, and allows for a reinforcement of the scaled movements. And one of the new addition to this platform is integrated fluorescence imaging capability. It provides real-time image-guided identification of the key anatomical landmarks using near-infrared technology. It allows the surgeon to visualize the end perforation of the tissue of interest. These are the different images which is showing the free degree of the freedom of the movement and instrumentation, and this is the image showing the fluorescence image fluorescence image which showing the different landmarks. And it also
No, wait.
Yes, sir.
Go back to that. See, Hari, have you understood what she just said?
Yes, sir. That artery definition. I mean, you're able to define fluoroscopy, like anatomy. That's what I understood from what she said.
No, not anatomy.
Tissue perfusions.
Okay.
There you come. Why didn't you mention that? See, the thing is, what happens is when you, when you're doing the resection, you have done the dissection, you have isolated the structures and everything, and then you do this study to show, for example, let's say you are doing an ultra low anterior resection. You want to show the segment of the colon that you are using for reconstruction, that is for anastomosis. You do this, the fluorescence imaging. It will show whether the segment that you are using is well vascularized and well perfused. So you will be absolutely certain that you are not using some dodgy area which may break down because of lack of blood supply. As you know, the left colon has suspect blood supply, so it is very useful. Again, if you are using it for pancreatic and other areas, liver resections and things, again, or for bile duct reconstruction, you can actually show that the vascularity of the organ that you are going to anastomose is good, is well perfused. Again, it will also show the bile duct anatomy and everything. So I think that is the advantages of fluorescence imaging that goes along with the robotic surgery. Okay, carry on.
And in telemonitoring, the two surgeons located.
But this fluorescence imaging can be used even in laparoscopy nowadays.
Yeah, of course. No, yeah. But it is now being built in with the robotic surgery. Inbuilt. Of course, you can use it in laparoscopic surgery, no doubt about that.
And in telemonitoring, two surgeons located at a distance away share the view of surgical field and control the robotic system and communicating via microphones. This system also has advantages of the teaching surgical skills to the junior surgeons and advanced medical students.
No,
and
wait.
Yes, sir.
Hari, can you tell me what is the major advantages of this telemonitoring system?
Comfort.
Two major advantages. Comfort and all that is there in every robotic system. Okay. This telemonitoring, what is the advantage? Abdul?
Sir, peripheral centers where the mechanism is inadequate, where the surgeons in some other place can guide the surgeons there for operating.
Yeah, but that is the purpose of telemonitoring. But what are the two main advantages? Kavya?
Abdul will later to take opinion or in war zones or.
Correct. See, the first thing is conferment with another surgeon. Whenever you are in difficult situation, anatomy is not clear, or you have a technical challenge, which you don't know how to solve, or you think it is better to take another opinion, the telemonitoring system will allow another surgeon to come online and then look at the monitor and then advise, or at least not necessarily advise. He can give his opinion. You can then discuss and miss one. So that is one major advantage. The second major advantage is mentoring. So if your teacher is, you are in a peripheral, you're in a different center starting, robotic surgery, you have, done the this one, the course and everything. You have done a few surgeries along with your boss. Then you have gone and peripheral, you branched out and you are starting your center. You can get, for the first few surgeries, you can have the telemonitoring where your boss will join you and then guide you through surgeries. And then after that, you can do it yourself. See, that is the mentoring system which is there all over the world. And even this mentoring does not mean that it is only for juniors or postgraduate students. Even, for example, let us say if I start doing robotic surgery tomorrow, I will have to go through a mentoring process by somebody who's already done a lot of them. So it is not necessarily for it is for anybody who is doing that procedure for the first time or for the first few times. And that same thing goes for all colorectal surgeries and liver surgery, whatever. The mentoring system is there now all over the world, where you, after you finish your training, you, for the first few surgeries, physically you have to get your bosses to come and assist you. But now with this robotic surgery, you can avoid them physically coming to you. You can do this from distance also. Continue, Ma.
Yes, sir. And the clinical advantages include, it includes smaller incisions and lack of fatigue during the operative procedures, and there is reduced blood loss and less pain, quicker healing time, and reduction of the complications. And it always includes reduced duration of the hospital stays and less transfusions and less use of pain medications. The technical limitations includes, the main limitation is decreased tactile feedback sense. That is the most common limitation. So that's why the robot is still a self-powered computer control device, not intended to act independently from human surgeons or to replace them. There are some crude haptics that occur if the instruments bump or hit each other, transmitting a tactile sensation back to the surgeon's console finger apparatus. And the minor limitations include the small operating space and bulkiness of the robot, and extended time to set up its position, and difficulty in traversing the wide fields. The clinical limitations, the major clinical limitation is the cost of the robot system, and the another one is it requires specialized training, and it also requires a steep learning curve to become proficient in the needed technical skills.
No. Wait.
Yes, sir.
See do you agree with this, Hari?
Steep learning curve, sir. Not sure. Learning curve is but almost same, sir.
Abdul?
Sir, for people who have already been trained in laparoscopy, for them, robotic surgery might not be such a steeper learning curve. But for people with only open surgery, who know only open surgery, it might be a steeper learning.
Kavya?
Actually, for a beginner compared to laparoscopy and robotic, it is easier learning robotic.
Absolutely. You hit the nail on the head. See, the thing is, you have to see, I will make 3 statements. Please follow this carefully. For surgeons who are operating only open, it is a piece of cake doing robotic surgery once they understand the robotic system, because they just have to do exactly what they are doing. See, this is the laparoscopic surgery. The movements are paradoxical. Here the movements are exactly as you see. What you see is what you get. So in open surgeries, what you see is what you get. You move your hand forward, and in the open field it's the same thing. In robotic surgery also is the same thing. So a proficient open surgeon will find robotic surgery very comfortable, because he's sitting and he is doing the surgery at the comfort, and basically he enjoys it, because it's exactly what he is used to and what he was doing all the time. So that is the first statement. Second statement is, for people who have not done any surgery at all, learning robotic surgery is much easier compared to learning laparoscopic surgery. Kavya said that correctly. So for a surgeon who is used to open surgery, robotic surgery is good and easy. And again, if you, as you are getting older, if you have developed tremors due to excessive alcohol intake or intention tremor, then those tremors will be, they will be compensated by the machine. So the tremors will be overcome. So that is the other advantage. And your movements will be more precise and fine. So the first statement is for people who are already, proficient in open surgery, robotic surgery is a boon. Second, people who are new to surgery and want to learn something, learn robotic surgery, because it's much easier to learn robotic surgery compared to laparoscopic surgery. Third statement, if already proficient laparoscopic surgeons, they have to adapt and change, because the movements in laparoscopic surgery are counterintuitive. Here it is intuitive, which means, the movements in laparoscopic surgery is paradoxical. Here it is the same. So laparoscopic surgeons may find it, no, they will adapt. No, it's not a problem. But if you look at the ease with which you do it, so the open surgeons and new surgeons learn robotic surgery much easier compared to proficient laparoscopic surgeons. Followed? All of you, any doubts?
No, sir.
Okay, continue, ma.
Yes, sir. So in conclude that it has robotic surgery has a tremendous change with advent and proliferation, and the Da Vinci system is the most commonly used robotic surgical system in the current era, and these future systems may shift the current paradigm to create more competitive market, leading to a subsequent decrease in the cost and greater availability of the robotic surgery to all. Thank you, sir.
Okay. Right. Closing comments, Abdul.
So she presented well, only the initial slides could have had more photos.
Okay, what do you think of the topic itself?
Topic is a bit dry, sir, but practical application with a console nearby and then explaining would be much better, sir.
Okay. Right. Hari?
Yes, the same like Abdul's robotic surgery. It will be more effective there, but the other points are well taken, sir. It is very well explained. Nicely presented, sir.
Okay. Srikanth?
A very good presentation. Which book you referred?
Sir, I took from multiple papers, sir.
Excellent, excellent. Very good.
Yes.
So, for my comments, Indraja, you have really taken a lot of pains. I think it's a literature that you have actually, you should share it with everybody. It's excellent.
Yeah, difficult to get information of robotic. No, until standard textbooks come out.
Yeah, you have taken a lot of pains to get glean information from everywhere.
Yes.
I think what Srikanth said was right. If you had found I should have mentioned that to you, small videos of each of these systems, it would have been more effective. But you have understood and presented well. And I think the topic is, as Srikanth again said, it is something that is, because it's a new thing, it would be better with practical demonstrations. So, and I think when you do that next time, what we can do is to get one of the surgeons who are doing robotic surgery regularly, so that they can give us insights and also certain, sort of.
You can add robotic postings 15 days, sir.
And then they can also give us this small, sort of fine points, which will help us, if we are going to become a robotic surgeons. Okay.
Yes, sir.
I think, I think good, well done, Indraja, you improved your presentation. Only thing is you use certain, for example, what did you say? I kept on saying this procedure.
Yes, sir. I'll change.
Where did you learn that word?
See, I think
Egyptian accent, huh?
No, idu Telugu. This is Telugu procedure. Just like
Samarasimha Reddy accent.
Amele, just like Tamilians, they say percentage, they will not say percent. 25%, 30%. So those,
Oh.
that is, I have seen every Tamilian, however good he is, will keep on saying 30%, 40%. You have to correct them, say 30%, not percentage. So I think that is probably cultural. It's not a criticism. It is of what you are used to, growing up. That's all. Okay.
I'll change.
Yeah. Good night, everybody.
Hello.
Huh.
You give the subject 4 or 5 days earlier so that if possible we can go search some book and we can also come up to date. 1 or 2 days means difficult.
Correct. I think ಅದೇನ್ ಮಾಡಿರ್ತಾರೆ ಗೊತ್ತಾ ಶ್ರೀಕಾಂತ್, ಇದು we will send you the ಇದನ್ನು ಕಳ್ಸಿರ್ತೀವಿ ನಿಂಗೆ.
But still, even
monthly,
when you're doing this talk, you can announce the next topic and next date.
Yeah. Okay, right.
That's a better thing so that we can also read and.
So next, what is Abdul? What is next class?
Power Journal Club is there, sir. Pawan's Journal Club.
That is when?
Tuesday, sir.
Next Tuesday.
Yes,
like that you can announce after along with thank you.
He'll send you the article. The Journal Club is on the hybrid repair incisional hernia.
That's what 4 or 5 days before you post it.
Okay, right. I think that's a good suggestion. Thank you.
Thank you.
Good night, everybody.
Thank you, sir.
Thank you, sir.
Thank you.